Hey everyone, I'm Lisa Maxon, and I'm a 12-year survivor of acute myeloid leukemia. Because of all that you do and all that you have done in the past, I received the double umbilical cord stem cell transplant. 12 years ago, I didn't even know what a stem cell transplant was, but I'm so thankful for it. I now get to see my 18-year-old live her best life, her senior year. I get to see my 15-year-old play football on the high school field, and I get to see my 13-year-old be his wild, crazy self. I appreciate all that you do and all that you continue to do for patients like me. Keep doing what you're doing, and I hope you guys have a great conference.
Well, welcome back. My name is Simrat Parmar. I am very honored to be here today to present this session, which is Literature Review and Best Abstracts. This session is actually very interesting because this is original research being presented by some of the pioneers in the field. And the way this session is formatted is that we have divided into initially the award ceremony, followed by the abstract presenters to present their research, and then lastly by the literature review. So to start this session, I would invite my dear friend and a trailblazer in this field, Dr. Colleen Delaney, who is also the Executive Vice President of the Cord Blood Association. She is the founder and Chief Scientific Officer of Devera Therapeutics, and she will be the one giving the awards to our winners. Dr. Delaney, please.
Thanks, everyone. First of all, to all of you sitting here, thank you for all of your tremendous work. You guys should be very proud of yourselves, and you get really cool little awards here, which everyone will see, and hopefully all of you out there will be encouraged to submit abstracts next year. I would encourage everyone not only to, obviously stay for this session and hear all of their presentations and the work that they're representing, but also to go to the poster session that will immediately follow this session where the rest of the abstracts will be presented. We are thrilled to have all of you here, and thank you to everyone else who did submit abstracts. So with that.
Thank you. So Colleen, if you can go down there, and I'm going to present. Okay. So that, where is our photographer? Right there. Okay. So best abstract number 1 is presented to Dr. Erin Morales Ubico for excellent events-free survival and immunoglobulin independence for patients with severe combined immune deficiency transplanted with umbilical cord blood cells. Dr. Ubico. Thank you. The second best abstract number 2 is awarded to Dr. Anthony Filiano. Umbilical cord-derived mesenchymal stromal cells suppress microglia activation induced by demyelination. The third award goes to Dr. Sarah Shields, identification of effective changes to workflow triaging criteria and production planning. The best abstract number 4 goes to Dr. Megan Fitch Edmondson, umbilical cord blood treatment to improve gross motor function in individuals with cerebral palsy, results from an individual participant data meta-analysis. Best abstract number 5 goes to Dr. Jazeen Kogler. Long-term stability of DUS cord blood units after greater than 29 years of cryopreservation. Follow-up data from José Carreras cord blood bank. Thank you. Best abstract number 6 goes to Dr. James Roper. Insights into highly engraftable hematopoietic cells from 27-year cryopreserved umbilical cord blood. Thank you, Dr. Delaney. Thank you. So with that, I would invite our first presenter, Dr. Erin Morales Ubico.
Thank you all, and thank you for being here. I'm going to talk to you guys today about excellent event-free survival and immunoglobulin independence for patients with SCID who were transplanted using cord blood. So as an introduction, we all know that HLA match-related donors is the preferred source for patients with SCID. Many patients lack a match-related donor, so alternative donor sources are needed. And umbilical cord blood represents a promising stem cell source. Looking at some previous published data from the PIDTC, back in from patients from 2000 to 2009, overall survival for patients with SCID was reported to be inferior based on donor sources at 58%. And then moving on to analysis performed in 2010 to 2014 on the right, you all can see that though overall survival was better compared to before, it was still an 81% overall survival for patients who were transplanted using umbilical cord blood for 31 patients. Looking at immune reconstitution, published by the PIDTC as well for T and B cell immune reconstitution. I want to focus on the B cell reconstitution on the bottom, which was defined as IVIG independence at a 2-year mark. And it was reported as being statistically significantly lower, particularly for patients who underwent or received a mismatch-related donor transplant. And the best was for unrelated donor transplants, and this is likely due to the use of MAC or RIC. So for our trial, the objectives of this study were primary outcome of interest was 1-year event-free survival, and the secondary outcome of interest was time to immunoglobulin replacement therapy independence based on donor source. For the methods, all patients diagnosed with SCID who were transplanted at TCH from the years of 2003 and 2021 were included, which was a total of 67 patients. EFS was defined as survival 365 days post-transplant without additional need for a transplant, a stem cell top-off, or a DLI. And the last date of immunoglobulin infusion was recorded to track the time to IVIG independence. A little bit about patient characteristics. The majority of the patients in this cohort were female, Hispanic. 89% of them only received 1 transplant, with the rest needing 2 or 3 transplants. And the median age of transplantation for these patients was 5.3 months. Looking at donor sources, as you can see on the bottom, umbilical cord blood was the predominant source utilized for these patients, with 55% receiving a cord. For the conditioning regimen breakdown, we have myeloablative conditionings, RIC, and other, of which the backbone for the myeloablative conditioning regimen was mainly BU-Cy, plus minus an additional agent, and with or without serotherapy, and this was 82% of the patients received this. For the RIC, we have RIC 4.5% of the patients, and for other, which included immune suppression or no conditioning, was 13.4% for our cohort. I want want to take a little bit of time to do a special mention for the regimen utilized for umbilical cord blood. So this is a myeloablative conditioning that does not include serial therapy. And the hypothesis behind using this in a prospective trial was that the omission of serial therapy may promote early immune reconstitution and reduce infection-related morbidity and mortality that had been seen before for these patients. So instead of serial therapy, fludarabine was added to a Bu-side backbone. And there were some special criteria that were required for the cord units. They had to be a 5 or 6 HLA, out of 6 HLA match. They had to be matched at high resolution at DR, and the minimum TNC for these units had to be above 5 E7 per kilo to help with engraftment. Cyclosporin and MMF were utilized for conditioning, for GVHD prophylaxis. And so looking at our results, for overall survival after stem cell transplant by donor source, there was no statistically difference between donor sources post-transplant. For EFS after transplant for donor sources, there was a statistically higher, significantly higher EFS for umbilical cord blood. When further analyzing this, this was just a difference between umbilical cord and haplotransplants. The cumulative incidence of IVIG independence according to donor source was statistically significantly higher for umbilical cord blood compared to all other donor sources. And I just want to take time to mention that the median time to IVIG independence for our patient cohort was 8.6 months, with a median time specifically for umbilical cord blood recipients of 7.6 months, leading to IVIG independence. It was 23 months for mismatch unrelated donors and MUDs, 26 months for haplos, and 32 months for match-related donor recipients. The cumulative incidence for acute GVHD among these patients was not statistically significantly different. And this was interesting finding for us because this was important because we did of the omission of serial therapy with the conditioning regimen. And so in conclusion, this single center cohort of 67 patients demonstrates excellent event-free survival for SCID patients undergoing transplant. EFS was highest among these patients. Patients transplanted with umbilical cord blood had a significantly shorter time to IVIG independence compared to other donor sources. And given the high survival of umbilical cord blood recipients and the robust immune reconstitution, we believe that umbilical cord blood may represent the best alternative stem cell source for SCID patients who do not have a matched sibling donor option. And with that, I wanted to thank especially our families treated at TCH, but have a special mention to all of our BMT and immunology team and acknowledge Dr. Krantz and Dr. Carrie Martinez, who's here today, and who have done an excellent job taking care of all of these patients, and this is all of their hard work that I'm presenting today. And with that, I'll take any questions.
They're all the way in the back of the room. That was beautiful data, like really. I'm going to ask maybe the same provocative question I asked yesterday. But first, you had the slide for IVIG independence. Was it literally 0%? Was that for matched unrelated donors? Is that the?
Yes, and the reason
matched related donors.
For matched related. And the reason for this is this data is looking at 365 days.
Sorry if my phone's up there doing an Amber Alert, sorry. I assume that's what that is.
And accounting for the patients who had to be censored, who required another stem cell infusion or a DLI or a top.
Okay.
So that led to that, yeah.
But I guess my bigger question was, with this data, and you had said, well, maybe, okay, I think I was mixing this up. I was kind of like, why not just go straight to a cord? Like, why are you even looking at any other donor source? That really was the crux of my question.
Sorry? Can you say that again?
Why consider any other donor? Oh. If you, when a patient comes to your center why are you not just going straight to cord?
Yeah, I think that's a great question. No, that's okay. I think, and obviously Dr. Martinez can also add to this because she has the majority of the experience, but I think the still kind of established norm and standard is using a match-related donor. our patients with umbilical cord do get a myeloablative conditioning regimen, so I think that's, you would still want to outweigh the long-term effects of the chemotherapy. But.
Yeah, at the beginning, before we started doing cords, they were not considering that. We were a haplo center before I got there, so we were all doing haplos, and when the cords started getting better, actually the first 2 cords were patients that failed a haplo. So they allowed me to do a cord on those babies, and they did so good that after that, that's the way we went. And there's almost all those patients are minorities, so there's not good donors available in the registry. So it's really make a big impact in our center. So now we basically, if we don't have a related donor, that's the way to go. And we get these babies transplanted very early because we get the course very quickly.
Yeah, and I just want to point out, because there are mostly minorities that we take care of, like, we just don't have a lot of match-related donor options available, so, yeah, okay.
Any other questions? Any other questions? So I have one question for you. In your haplos, did you do post-transplant Cy, or did you give them cyclosporin MMF?
No. So due to the years that this happened, most of these haplos were CD4 selected stem cells.
Okay. And number two is, in terms of the weight-based dosing, was there any difference between the haplo versus MRD versus cord blood in terms of your CD34?
I'm sorry, I'm not sure
Okay.
the answer to that question.
Thank you.
Yeah, thank you.
So I would like to invite our best abstract number 2, Dr. Anthony Filiano.
All right, I think I first wanted to thank the association for giving me this opportunity to discuss some of the unpublished data from my lab. I have some disclosures, and I thought this was a good time to disclose that as any PI, I don't really do the work. So this was all done by a talented research scientist, Li Shu, in the lab. All right, so my lab is really interested in developing cell therapies for demyelinating conditions. And so this would be like in a CNS autoimmune disease or in CNS injury. And a really potential target is macrophages. So in the CNS, these are microglia, and they have a very complex and critical role in the process. So they can promote neuroinflammation, but they also can promote neuroprotection. So for example, microglia can release pro-inflammatory cytokines. They can also present antigens and exacerbate the immune response. And they also can play a role in cleaning up phagocytosing myelin debris and play a role in tissue rebuilding. So they're really like, to use a Miami analogy, they're really like the Lionel Messi of the response. So things can be going really bad, but as soon as you get them on your team, things are going to turn around. So it's a really complex response, and microglia undergo very global transcriptional changes. So I'm just listing some of the canonical genes, but this was really the goal of the project, and to take a complex system and develop a toolkit of assays that ourselves and other labs could use to investigate these processes with different complexities. And so since microglia have such a yin-yang response, we thought that conventional therapies like small molecules would be kind of limited. So we got really interested in mesenchymal stromal cells that really act as a smart drug, as you can see here, and many of you are probably aware. And so a couple years ago, we published this study that if you inject umbilical cord-derived MSCs into the blood IV, they traffic to the lung, interact with macrophages, suppress them, and are protective in a lung inflammation model. So another group had published in a CNS injury model, if you inject them into the cerebral spinal fluid, they also co-localize with macrophages, and these macrophages upregulate the tissue healing marker YM1. So we thought, do they interact with macrophages in spinal cord injury and demyelinating diseases? So this is our model. A talented GMP team produced these MSCs from umbilical cords. They pass them to us. And this is our model system where we do an acute demyelination of the spinal cord by injecting LPC. And then 3 days later, we can inject MSCs into the cerebral spinal fluid, and then analyze tissue 10 days later. So you can see by looking at the Luxel-Fast blue, this white area there, you can see the demyelinated area when you inject LPC. And then when we added MSCs, you can see that it promotes this spontaneous remyelination. So how does this happen? We looked closer at the macrophages or microglia. And to do this, when microglia activate, they kind of shrink up and they become less complex. And so we can analyze this by drawing concentric circles and looking at how many branch points cross those circles. So you can see in the open bars here, the control condition, they have a really nice branch point, and when we add LPC, you can see they get less complex with a shift down in that line. If we add MSCs, you can see that it looks more like that control condition. So MSCs suppress microglia, at least their morphology. So to get a better understanding of what's going on here, she isolated primary microglia from the brain, cultured them, and then since we don't have myelin in this condition because they're isolated microglia, we activated them with LPS, lipopolysaccharide, and then added MSCs 1 hour later, and then did a little bioplex assay to take an unbiased approach to look at the release of cytokines. And she noticed that TNF was up in LPS, and this was, out of the limited cytokines that she looked at, TNF was suppressed by MSCs. So is this happening in the spinal cord? So a similar assay, she goes in, she injects LPC for this acute demyelination, injects MSCs 3 days later, then she took out myeloid cells from the spinal cord, put them in culture, and then analyzed them by flow cytometry to see what they were producing. And what she found is that when she gated on microglia there, you can see in the gate, you can see that with LPC there was a shift in them producing, in the histograms, them producing TNF, and then in the mice where she injected MSCs, it could suppress this release of, or this activation of TNF, production of TNF. And that's shown here. We also wanted to validate this in a single ELISA where we're just looking at TNF, so basic assay, and she was able to reproduce these results here, and you can see the morphology change also. So these assays are complex. They take a lot of time and experience, and so we wanted to see if we could create a more simple assay. So she took microglia, primary microglia, and froze them and thawed them out. So if you're running an assay, you could just pull them out of the freezer, run your assay. There was decent viability, as you can see in that graph. And they were also able to suppress the activation, release of TNF. So again, these primary cultures are less complex, but they still involve a lot of steps and mice. So we used a microglia cell line called IMG, and you could see what they look like here. And then she activated them with LPS, added the MSCs, and then analyzed TNF by ELISA, and they could suppress the activation and release in TNF. And you could see the timeline is much less here. So to conclude, I showed you that MSCs, they can suppress microglia production of TNF after acute demyelination. We showed this in multiple assays differing in complexity, that they were able to suppress TNF production. And then the IMG assay seems to be a nice assay that can be further developed into a potency assay. And so this is just basically showing you what I said there. I didn't have time to talk about the slice culture, but you can see that here. So here's the acknowledgement slide. This is my lab here, so Li Shu, you can see there. And then I just wanted to point out the funding, especially the Cord Blood Association Foundation, who was critical to get these experiments off the ground. So thank you.
Hi, I'm Megan Capitano. Quick question. TNF is also known to act on MSCs, though, to promote MSCs to polarize macrophages into an anti-inflammatory style macrophage. Have you looked to see if there's any feedback loop to the loss of the TNF?
Yeah, that's a loss of TNF.
Well, you had a reduction in the TNF.
Yeah, so that's a great question. Just kind of sidestepping your question, but so we were able to only analyze TNF released from microglia, so this doesn't account for TNF released by MSCs. But to answer your question, we didn't look on how, specifically in our models, how TNF can impact the MSCs. And what's even more complex is, as you probably know, there's soluble TNF and there's also ligand-bound TNF, which kind of has different roles as well. So in most of these, we're just looking at soluble TNF, which has been pro-inflammatory. So great question.
So first of all, excellent work. I have a question for you, and I may have missed it. What type of mouse did you use here?
The background strain,
Yeah.
this is a black 6, C57 black 6.
So, and you used umbilical cord blood-derived MSCs?
They're human umbilical cord-derived, yes.
So in this xenogenic model, you were able to see the effects, because usually we are using non-skid gamma-nil mouse to look at xenogenic effects. So I'm just trying to see that, how you were able to overcome that barrier.
We've used a lot of models where we're using that xenograft, and we think we showed that, we published that they will interact, so the human cells would physically contact the mouse macrophages, and they reprogram them that way. And so the effects are not dependent on MSCs lasting for long periods of time. We think that brief contact can actually reprogram macrophages and change the trajectory of the response.
Thank you.
Yeah.
If no other questions, thank you so much. We'll invite the next speaker.
Thank you. This is an honor to be here. This is a very long title, Identification of Effective Changes to Workflow Triaging Criteria and Production Planning. I promise it's not that scary. We will get through this together. I have no disclosures, although I will say, like Donna Reagan, I am a proud med tech. I'm not a doctor, but med tech, yes. Really quick about the Cleveland Cord Blood Center. We were established in 2008 by Dr. Mary Laughlin. We are a public, not-for-profit cord blood bank. We are AABB and FACT accredited. We received our FDA license in 2016. We have over 85,000 cord blood units collected from donors in Cleveland, Atlanta, San Francisco. Over 11,000 frozen products in inventory. And we've distributed almost 800 cord blood units for transplant. And for me, that's what really keeps me coming back every day, year after year. Just knowing that it's going out to a patient in need. It's a second chance for someone that might not otherwise have it. So I just love that. All right, so I'm going to talk quickly about, I'm going to show you some data. I'm going to explain how and why we made changes to our triage criteria, and then summarize the impact of those changes. So as promised, this is the data. I started looking at this about a year ago. These were units that were manufactured January through June of last year. And we found that about half of the units that we manufactured for clinical transplant, only about half were meeting our licensure criteria, which ideally every single unit that we would process, we want to meet the licensure criteria. About 13% were unlicensed, and this was due to their eligibility. So they were ineligible, typically due to travel to Zika areas. And then about a third of the units were deferred, so they were not meeting our criteria for licensure or our post-manufacturing criteria. Some of these could be used for research, depending on why they were deferred. So the question was, how can we reduce deferral rates and increase the number of licensed units? So what we did was we created 4 cross-departmental teams. Each team had representation from collections, quality, and our processing staff. And the teams looked at the main reasons why units were either deferred or ineligible. We focused on 4 main areas, dividing the teams up, one into product characteristics, so looking at TNC, CD34 count, contamination, donor-related, and then personnel and equipment. And we told the teams, look, there's no bad ideas, just work together, come up with ideas, short-term, long-term solutions, and then bring that back to the management team. We discussed it as a group, and we decided which items were feasible and which ones we were going to implement. So the 2 I want to focus on today, the first one is from our product characteristics team. They found that of the units that were deferred, about 20% were related to low CD34 count or viability. So their solution was implement a pre-processed CD34 count and viability screen prior to manufacturing. Now, this is not something we had done before. We've always had a volume cutoff and a TNC cutoff. Typically, if you have a high TNC, you will have a higher CD34 count, or at least high enough. So it wasn't something we had done previously. And then our donor-related team, they found of the available units, about 17% were unlicensed due to travel to Zika-related areas. So their solution was, after consent, prior to manufacturing, ask travel-related questions to the donating mother. Typically, we ask the full questionnaire after the unit is manufactured, so we get that information after the fact. So if we moved it up to the beginning of the process, we could find out who had a travel risk. There was also a financial incentive behind this. Units that are ineligible, they cannot be licensed, they cannot be HRSA funded. So we definitely, that went into consideration when we said we weren't going to process these units. So this is our snowman, our triaging criteria snowman. So like I said, we have a volume cutoff. Those that meet the volume, we perform a TNC count on those. And then we added the following 3 criteria: CD34 viability, the count, and the high-risk travel evaluation. If it met all of the criteria, then we could process it for clinical transplant. If it did not meet any one of the criteria, it would be available for research, QA, or QC. We found that about 75% of the units met the TNC count, and as we added each additional criteria, we would lose about 10% of the units. So in the end, about 50% of the units were meeting all of the criteria. So then here are the results. We have info from March through May of this year, and we compared it to our original data set. We found a 6% decrease in deferred units, and we actually had no units that were deferred due to low CD34 count and or viability. We had a 15% increase in units meeting licensure status, and this was directly related to not processing units with high-risk travel. And then of the units that we processed, like I said, they were meeting the licensure criteria. So what happened was we manufactured less units, but we also had less units that were being deferred. Of the units that we processed, more were meeting the licensure criteria. This resulted in net cost savings overall, about $25,000 per month. So these were excellent results for us. Now there's a lot of banks, a lot of different triaging criteria. There's just a couple key points I want to highlight from what we did. It's really important to collect, review, and use the data. So you can't just collect information, let it sit on a shelf somewhere. You have to use it, let it guide your research, have different people look at it. They'll have different interpretations. And that's where these cross-departmental teams were really important. It helps with project support, buy-in. Everyone's aware of what's happening and why, and that helps make implementation easier. And it's just great to have a lot of different ideas from different parts of the organization that you might not think about. And then I have a public health background, and public health is a lot about prevention. How can we prevent things from happening? So what you want to do, like if you're stuck in a problem or situation, if you take a few steps back and look at the upstream changes, can we make changes higher up in our process? Because if you make some of those small changes higher up, they will have big impacts downstream, which is what we found. And finally, this is a continuous process improvement. It's not one and done. We will continue to review the data. It's important to look at what happened, what you implemented. Can you make improvements from that, both short and long term? A lot of people to thank. I'm just here representing the Cleveland Cord Blood Center, but this was a huge amount of work. A lot of SOP updates, worksheets, job aids, training. It took several months to get this implemented, so big kudos to our team. Thank you, everyone. Appreciate it.
Quick question about how did you manage the time that it took to do the CD34 analysis and the maternal screening before processing? Because that doesn't happen in a scan.
No, yeah. So the maternal screening, it would happen at the hospital after collection, but before they sent the unit to our processing facility. So when they sent the unit, they would send that information with the unit. So we knew when we received it if it had a high-risk travel or not. And then as far as the CD34 count, it did add an extra 45 minutes to an hour up front, but we found it was worth it in the end.
Hi Sarah, great talk. Philip Johnson from the Queensland Cord Blood Bank in Brisbane, Australia. Just a quick question, did you do any investigation to look into and perhaps identify why you were seeing low CD34 viability in the units when they were received into the laboratory?
Yeah, that's a great question. We couldn't pinpoint why we were seeing more units were having a low CD34 count. We do see, I can't really say. We couldn't pinpoint why. Do you think that was
linked, was there any link to the length of transport time or how they were, I suppose, handled during transportation from your remote collection sites? I'm interested if there was any sort of root cause that you identified as part of that investigation as well.
It's a good point. I don't think it's related to that because our travel, system is validated and standardized, so it should be the same every time. But like I said, we couldn't really pinpoint why we were seeing those units being deferred.
It's a great presentation, Sarah. Thank you. Did you look at the different, how many units were actually viable, that had a viability issue versus the low CD34 count? Which one was more impactful?
Yeah, so it was more units had a lower CD34 count versus the viability issues. Yep, great question.
Thank you.
Thanks.
I would like to invite Dr. Megan Finch-Edmondson.
Good afternoon. I'm absolutely delighted to be here presenting this study on behalf of all of the co-authors. And here are my disclosures. So cerebral palsy, or CP, is the most common physical disability of childhood. It's a lifelong condition which affects movement and posture. And current options for treatment are currently limited, and there is no cure for the condition. Cord blood is one of several cell therapies currently under investigation for the treatment of cerebral palsy, and this is due to its immunomodulatory and anti-inflammatory actions, and this has been demonstrated over decades of preclinical research. And cord blood has also been under investigation in human studies for more than 15 years, and this includes 7 randomised controlled trials which have been published with nearly 800 participants treated, and systematic reviews have demonstrated that cord blood used in this way is safe and can improve gross motor skills. But despite being the most well-studied cell therapy for cerebral palsy, it's important to note that cord blood is not yet approved for the treatment of cerebral palsy, as I'm sure you all know in this audience. And if we look at the research landscape, it's quite easy to see that we are missing a phase 3 trial for this condition, and this is really the next critical step for the field. However, another issue that we're grappling with in this area is high heterogeneity in the existing research data, and this can lead to uncertainty in the true effect of cord blood treatment for CP. And this heterogeneity can come from the condition itself. So cerebral palsy is a highly heterogeneous condition, and we've seen differences in participants in terms of their age treated, the severity of the condition, and even the type of CP. But also we see variability in the treatment itself. So we've seen a wide range of doses used and even cord blood given by different routes of administration. And all of these factors could contribute potentially to the response to treatment. And so our solution to this heterogeneity was to conduct an individual participant data meta-analysis, or IPDMA. And the objectives of this was to, first of all, determine the overall effect of cord blood treatment, and we specifically looked at gross motor function, and this was measured using the Gross Motor Function Measure, or GMFM 66. But then we were also interested in understanding the effect of cell dose on clinical improvement, and we were also interested in looking to see if we could identify responder subgroups, and this was initially focused on looking at participant age as well as cerebral palsy severity. And our approach that we took was to first conduct a systematic review to identify eligible clinical studies indicated here, and then obtain the de-identified individual participant data for analysis. And this is an overview of our included studies. So from 13 potentially eligible reports, we were able to obtain data from more than 200 cord blood treated participants and 171 controls. And here is the characteristics of these included studies and participants and the data. And whilst I won't go into all of this detail, just to point out a few key things. So just over half of our participants were classified as moderate to severe cerebral palsy, so that's GMFCS level 4 and 5. Our mean baseline age was a little over 4 years, and you can see that our cell doses ranged from 7.7 million cells per kilo all the way to over 200. So what did we find? Well, first of all, looking at the overall effect size. So looking at both the 6 and 12-month time points post-intervention, we could see a positive effect of cord blood treatment above that seen for the controls, and this was statistically significant at both those times. Next, looking at the effect of cell dose. Well, here we have these dose response curves where on the vertical axis we have the effect size and along the bottom cell dose, and hopefully you can see from these graphs that we see a positive trend of increasing effect size with dose, and this was statistically significant at the 12-month follow-up time point. But I think what's really interesting about this data is that it does suggest that we are yet to reach a maximum effective cell dose, and perhaps we should be looking to dose at even higher levels. Then moving into our responder subgroups. So first of all, looking at severity. And we saw that at both the 6 and 12-month time points, there was a clear difference in participants who had less severe cerebral palsy compared to the more severe. And that was statistically significant. So the clear take home there is participants with less severe CP did better. And then finally looking at age at baseline. So again, we've got these curves with effect size along the vertical axis and baseline age along the bottom. And we can see that as the participants got older, the effect size decreased. So really, we need to be treating earlier to see that effect, and that's really within the first few years. And again, that was statistically significant. Of course, it's important to consider the clinical significance of these findings, and I've popped QR codes for 2 papers that have published minimum clinically important differences for the GMFM66. And you can see that our observed effect sizes do fall within this clinically meaningful range, particularly for those participants, for example, treated earlier with higher cell doses and less severe. So in conclusion, we were able to demonstrate there is a clinically meaningful effect of cord blood treatment on gross motor function, and we were also able to identify some responder subgroups. Additional analyses are ongoing, but I also wanted to point out that due to the availability of data, we were only able to look at gross motor function in this study, and potentially in the future, other benefits should be explored. And we believe that these findings will be useful for the design of future studies, and there are clearly opportunities to optimise this treatment going forward. Thank you very much.
So thank you. Very, very good data. I have a couple of questions, a very stupid question actually. When you say cord blood treatment, what do you mean? Is it transplant? Is it infusion? What is it?
Yes, so it's an infusion is how we would refer to it. So there is no, preconditioning, no immunoablation. So it's not considered a transplant. The cells are primarily given intravenously. One study did administer them intrathecally.
Okay. So my second question is that this is incredible that you're giving them without conditioning and just giving the whole cord blood unit as treatment. Okay. So what do you think is the, potential biomarkers? What is the durability of response? Because I totally agree with you that there is definitely very strong data to support this. But, just coming from my own experience, I think one of the bottlenecks or one of the problems that we run into is that people need to understand why it works, how it works, what is the probability, and if there is any pre-treatment predictive analysis or some kind of biomarkers that you can detect to say that, this is the subgroup that would benefit from it or not.
I think it's a great question, and I think it's something that the field has struggled with, is really pinning down mechanism of action, although there's nice preclinical evidence to suggest how that's working. In terms of identifying the responders, I think that hopefully this analysis is giving us some of those clues. Whether we need some kind of biochemical indicator of who to treat, I'm not sure. But I think this is a good start, at least from a clinical characteristics point of view.
Yeah.
So if I could help with the answer to this, we've shown in the work we've done treating kids with CP with cord blood infusions that they're signaling from the monocytes in the cord blood that enables myelination of motor tracts in the brain. And we've shown that on certain types of MRI in the children treated on our study. And we think that's the mechanism of action.
To follow up that question, then, is there any correlation with the durability of response? Because this is one and done and sounds fantastic, but, I'm pretty sure that it's not 100%. So is there any ability to sift and sort through that data? Because I think the preciseness would be what will lead to success.
Is that also in terms of whether repeat dosing?
No. What I meant is with the defining of the monocyte population, and these are the ones that can probably mediate most of the inflammatory, and then the cord blood treatment actually absolving it. But my question is that does that also then translate into durability of response? So if you're seeing that there is a certain delta that allows for you to actually predict that this patient is going to benefit versus not.
So I can help with that in the sense that this is published, but in our first randomized placebo-controlled phase 2 trial, we had a crossover at 12 months. So children were blinded, but either received placebo first, cord blood 12 months later, or cord blood first and placebo 12 months later. And then they were also analyzed a year after that second point, so at 12 months and 24 months. And in the children who got cord blood first, so at time 0, who were then seen at 24 months, there was no loss of effect. And I think that there's, if they gain certain types of function, they can build on that as long as they don't lose it. So if you couldn't use your thumb before, and now you can use your thumb, there's a whole lot of other things you are enabled to do. Or if you couldn't use, if you had paralysis of one extremity and then you gain more function there, and you don't have a recurrence of the low tone or spasticity or whatever it is, then just it's iterative. The child gains more function by being able to use that limb. So, but we did not see loss of the effect at 24 months.
Yeah. And yeah, the participants received standard care, so that would have undoubtedly included rehabilitation. So absolutely, I think that this should be seen as an adjunct to existing standard care.
Well, does that correlate with your finding? I was going to ask some of these questions. Does it correlate with your findings of earlier treatment is better? It seems to be the durability of response might also be correlated with what you have just been talking about, right? The earlier you treat.
Well, also with brain development in general.
Right.
There's more plasticity in a 2-year-old brain than a 6-year-old brain than a 10-year-old brain. Yeah. I don't know I don't remember the median age here, but most of these studies have been done in younger children. And if you look at the GMFM, really past age 6, regardless of level, in natural history of CP, because the GMFM was actually validated in children with CP, and it shows natural history of motor development based on age and level of disability. And after age 6, the curves are pretty stable.
I'm sorry to take more time, but Dr. Kurtzberg, then I have this question for you. I think this data is extremely compelling. Is there a way that this data can be presented for provisional approval while you're doing the phase 3? Because if I have a child,
I wish.
You've tried.
FDA's told us we're applying for our RMAT with Cryocell, the company that licensed the technology or the IP and our regulatory and data packages from us. We are now committed to a phase 3 randomized registration trial in the US. But no, FDA was not willing to look at the phase 2 data and just move forward. I wish they would have.
So I agree with you, Simran. I think this is one of these examples that's been great coming year after year. Again, I'll make a plug for people to continue to come to hear this. When it first started, I think there were a lot of shaking of the head and like, this is voodoo and what are you talking about? So this was a really great presentation. I guess I might have missed this. I think this was a combination of auto and maybe sibling cord blood. And you had mentioned that cell dose, we haven't reached the limit or whatever. But this is one cord blood per recipient. So I assume these patients get all you have? Or is there a cell dose cutoff? Can you literally give more, I guess is my question.
Yeah, I'm happy to say something, but I'm sure Dr. Kurtzberg will want to add to that. So some of the studies did set a maximal allowable dose. We've seen over time that the doses have gone higher, so some of the earlier studies, and actually even some of the new studies were still dosing quite low, disappointingly. These are small children. If we're looking to move forward and we're really talking about treating only within potentially the first few years of life, I think going to higher doses shouldn't be so much of a challenge. And most of this data, so I think it was over 80% of participants received allogeneic cord blood.
But, to one of the prior questions, because of allo sensitization, I think it would be difficult to expose children to subsequent doses, particularly as they get bigger, because it's one cord, one dose. We have actually, when we could think about it in advance, split the cord if there was enough to give more than one dose, but we're only talking about 2 doses. We're not talking about 20 or, yearly dosing for 5 years or anything like that.
I think this is fantastic, and we should definitely discuss, but congratulations, this is really groundbreaking. Thank you so much.
Thank you.
So thank you for inviting me, and thank you for giving me the possibility to discuss the long-term stability of our cord blood units after 29 years of cryopreservation. And thank you for the award, and the award will go to my team, I think, because this is a long-lasting work. So the cord blood banking started in Düsseldorf in 1992 with so-called directed related donations, and we learned the technique at this time from Eliane Gluckman at the Hôpital Saint-Louis. And since 1993, we store allogenic unrelated donations, and we have introduced segments into the cord blood units in 1996. Since Germany is unfortunately a heavily regulated country, they determined cord blood as a blood product, and that means that we have to go into license already in 2001. The regulation was passed in 1997, and so we got our license in 2001, and we got the FACT accreditation in 2004. Today, our cord blood bank has 21,000 active cord blood units who are all cryopreserved in the liquid phase of nitrogen. We have released 16 directed donations, and we have released 1,500 cord bed units for allogenic transplantation. Based on the law in Germany, we had to install GMP very early. That means full GMP, meaning ISO 5 in ISO class 7. And we have 5 clean rooms, and each clean room is used for a different product. So we started with these projects very, very early. For all our products, the most important thing from the beginning on was that we stored everything in the liquid phase of nitrogen with an overwrap bag. And according to our quality criteria, we started already 12 years ago to cryopreserve only high TNC numbers and also high CD34 numbers. And we qualified our units both also for the viability of CD34 after thawing, but still also for CD45, because we feel that this is an important parameter. So based on the requests of our regulators, the Paul-Ehrlich Institute, we always have to do the stability of our cord bed units every 2 years. Going back to unseparated units in 1992, 1993, where we cryopreserved simply in HSA and DMSO. Since 1998, we stored we manually processed cord bed units using HAS according to the method developed at the New York Blood Center. And since 2005, we went into the automated volume reduction with the CPAX 100. And it's a little bit small, but I can tell you we haven't seen any differences when we discuss the viability and the stability of the cord bed units 29 years ago as compared to 25 years ago as compared to 18 years ago. However, of course, as all other cord bed banks, we saw a trend in the cord bed inventory, and correlating with the cord bed inventory, we of course observed also when we provided transplants a high cell count for the transplants we provided over time. However, and this is shown in the lower row, we observed, of course, that the transplant centers were requesting mainly young units over the last 5 or 6 years. And, of course, TNC and CD34 rich units. When we compare our inventory to the data obtained from the WMDA in 2022, you will see that we have a high qualified unit starting with 1.5 to 10 to 9 cells, and an average 30% of the units fulfilling the criteria to have 1.5 to 10 to 9 cells. And we feel this is also extremely important for the quality of the banking. When we analyzed the released transplants related to the TX delivery date, we could see that the TNC counts, the TNC recovery CFC count results improved corresponding to the distinct processing method and to the transplant delivery date. However, we did not observe differences in the TNC viability after TOR, and we did not observe differences in CD34 and CD45 viability, and also not in CFC viability, independent whether the cells were from 29 years of age or later. However, what we observed that in the volume-reduced groups, starting in 2005, as compared to the unseparated units correlating to the TNC counts per kilogram body weight and CD34 counts per kilogram body weight applied for transplantation, we observed, of course, a difference. And earlier engraftment was also described, of course, for the volume-reduced units. However, we could not show in the stability outcomes of the released transplants in correlation to the storage time, no significant effect of cryopreservation determined for released transplants on engraftment time, applied TNC count per kilogram body weight, and applied CD34 dose per kilogram body weight. However, when we looked at the probability of engraftment, this was not statistically significant. However, the automated volume-reduced transplant reveals the highest probability for engraftment within 42 days, and unseparated units reveal the lowest probability. However, after 60 days, interestingly, the group of unseparated transplant overtakes the highest probability of engraftment at the endpoint. So the quality of engraftment was a little bit delayed for the unseparated unit, but not statistically significant. So for us to go into the study, it was extremely important because our bank is also developing from cryopreserved homozygous cord-derived units, ATMPs, advanced therapy medical products. And we don't want it to restrict us with the HLA types to younger units because we could identify 139 homozygous units in our bank. And so we wanted to go back also to old units in order to qualify them for an automated product. So quality and storage was everything for us. And even when we taught these old units for CD34 selection expansion, we couldn't see a difference to the newer units. And also we have another topic on screening the cord bloods where we need to isolate B cells and CD34 cells from elderly units, where we need substantial cell numbers and RNA from the cells. We observed that it's very efficient if you choose products who have really a high viability, if you screen them, for instance, for genetic diseases or even for research projects. When you define, for instance, 84-6 Strong's translocation, and then you isolate the cell population as B cells, CD34 cells, because if your viability is not high enough, you have a lot of problems on the isolation of, for instance, RNA from CD34 or B cells, because they contain so few RNA. So if you are interested in, you can go to poster number 23 and 24 as a follow-up project. So in summary, cord bed stored for 29-30 years, having a high stability if stored in the liquid phase of nitrogen. The products can be used for isolation of CD34 cells for clinical expansion. They can be used for the generation of iPSC, but of course for transplantation. And they are also an excellent source to perform genetic screening studies if a cell population can be isolated with a high viability and quality, and this is extremely important for us. So at the end of my presentation, I have to thank really our institute because we never got financing from our government, and I'm also very grateful to the José Carreras Foundation who funded us until 2007. Since 2007, we must be self-sustaining, which is quite a hard job to do. And I also mainly have to thank my team who were co-authors here on the publication, and mainly also Eliane Gluckmann for the long-standing collaboration with EuroCord, where we get the clinical data from, and also from the CIBMTR. And we also thank, of course, all our collection centers helping us out for nearly 30 years. And for me, we honor and remember Hal Broxmeyer because he initiated all this work, also work on stability studies. And I'm happy that James will maybe give a presentation which is complementary to our presentation. Thank you.
Thank you so much. We have surpassed our time, so I'll invite our next speaker. Dr. James Roper.
What a fantastic meeting, right? I heard somebody from the audience ask for more stability studies, so we're going to give the people what they want. Today I'm going to discuss insights into highly engraftable hematopoietic cells from 27-year cryopreserved umbilical cord blood. And I'm going to take sort of a more basic science approach to this. I am a basic scientist. It's been fantastic seeing how all of this stuff gets applied in reality to patients. It's been really, really a fantastic meeting so far. So this really wonderful paper here discusses guidelines for cord blood unit selection written by a real who's who of Cord Blood Connect. And they did acknowledge in this paper, which I really appreciated, that it's believed that cord blood units have very long stability. However, most centers do still select based on unit age as one of the exclusionary criteria. And in this paper specifically, they said generally 15 years is considered sort of the cutoff point for that. And my mentor, Hal Broxmeyer, thought that was a little bit silly because he didn't believe that these units really had a shelf life. And so that's where we kind of dove into this project. So the question that we're asking here is really, should duration of cryopreservation itself be an exclusionary criteria for selection of cord blood? And if not, can we identify criteria that can aid in that selection? And so we received these 27-year cord blood units from our collaborators at the New York Blood Center. And actually, after some input from Dr. Emmeline Fournette, she also recommended looking at 3-year-old cord blood units, so they sent those our way too. We compared these units to fresh cord blood obtained from CryoCell or from the Cleveland Cord Blood Center. And then we enriched CD34 cells, and we really just threw the kitchen sink at these cells. We decided to analyze them in pretty much every way that we knew how to on the bench side of things. And so to start showing some of the data here, these are the units that we have. You can see the age of the 27 years, the 3 or less year old. In terms of viability, these cells are very similar in viability, the long-term compared to the more short-term cryopreserved cells. We then started doing some immunophenotyping based on cell surface staining and flow cytometry. We looked and saw that as a fraction of low-density cord blood, CD34 cells also had very similar numbers in the long-term cryopreserved compared to the short-term and compared to fresh units as well. And we actually, I didn't show this data because it's a 7-minute presentation, but we showed it as a fraction of the unit, the total number in unit, a fraction of volume, a fraction of total nucleated cells. And so really in any way you look at this, the same number of cells are there in terms of CD34 count. We also did some more specific, stringently defined immunophenotyping, looking at hematopoietic stem cells and a whole host of progenitor cells. I'm showing a representative of the multipotent progenitors here. And what we found again were that these long-term cryopreserved cells units have the same number of stem and progenitor cells as the more short-term or the fresh cord blood units. We then looked at colony-forming units. You can see the growth factors that we added to these to get these different colony-forming units. And what's been reported before is that post-thaw cord blood units have worse colony-forming capacity than compared to fresh, and that we showed here as well. That's been reported by Joan Kurtzberg's group as well as a number of others. But I think what's important here is that if you look at the 27-year cryopreserved compared to the 3-year-old cryopreserved, there's again not a statistical significantly different number of CFUs. So it suggests that the potency of these units is also maintained. And again, we showed this as a fraction of all the different parameters that I mentioned earlier. We also did some expansion studies looking at this entire host of progenitor cell populations as well as stem cells to see if these cells maybe had different proliferative capacities ex vivo or not. And they, again, showed very similar proliferative capacities as the 3-year-old cord blood, and oddly in some cases better expansion capacity than the fresh. The only thing that was really different in the fresh was that the fresh had better expansion of the granulocyte macrophage progenitor cells. We're still kind of digging into that to figure out what exactly all that means. So next we wanted to look at the in vivo engraftment capacity of these cells. And so we employed an immune deficient NSG mouse model where these cells were transplanted at a limiting dilution to the mice, and we showed that these mice are able to be engrafted at early time points, so 4 weeks post-transplantation, with all 3 of these 27-year-old cord blood units. They show very low to robust engraftment 20 weeks post-transplantation in these mice. You'll notice this one unit here that I'm going to come back to in a little bit. And then at 20 weeks post-transplantation, they also have a very defined myeloid skew which is very common in these mouse models of transplantation. So really these cells are behaving the way that we expect any fresh cord blood unit to behave. And in fact, when we use linear modeling to actually calculate the SCID repopulating frequency of these cells, basically the number of cells per million that are injected that actually have the ability to reconstitute the mouse, we find that they have very similar frequencies compared to a whole host of published data of cord blood units that were either frozen more recently or were fresh, except for, again, this one, which I'm about to talk more about now. And so as we were doing these studies, we noticed that there were this one cord blood unit that had very poor engrafting capacity compared to the other 2 that had very high engrafting capacity, and we decided to harness that and leverage it to see if we could figure out what are the gene programs that are at play in these different levels of potency. So we did RNA sequencing analysis on these cells and used the generalized linear model to determine if we could find gene programs that are associated with cord blood engraftment and potency. What you'll notice that I just want to show from this data here is that cord blood 397, which is the one with the poorest engraftment efficiency, actually looks the most like fresh cord blood. So we don't believe that these differences are actually due to cryopreservation issues. It's something inherent in the unit itself. Maybe it's from the processing or the collection, something inherent in the unit itself. So we did the analysis on these gene programs that are altered. We found a lot of genes that are significantly upregulated and a lot of genes that are significantly downregulated in the high engrafters compared to the low engrafters. And these genes that are changed are enriched for programs such as the HOXA5 driven program, which is associated with self-renewal, the HIF1 alpha pathway, which is associated with hypoxic responses. And so we were able to identify some programs that might be useful to defining cord blood potency and stem cell potency. And I just want to show this. It's a busy figure, but I want to show it because I think it's cool. We looked at all the genes that are really stringently changed. It's a low sample size, right? And so there's not a lot of power. So we added some really stringent filters and settled on this list of genes that are changed based on engraftment in the stem cells or the multipotent progenitor cells that we looked at as well. The ones that are highlighted are the ones that are changed in both. And what we think we found is sort of a list of candidate targets that could essentially be associated with potency. And actually, we've been able to validate some of these. So we, by flow cytometry, looked at CD22, this marker here, which I picked because the reviewers asked for it, and CD22 is a surface marker. It's really easy to look at by flow, so that's what we went with here. And so we looked at the expression of it on independent cord blood units. So these are 3 independent cord blood units that we had frozen away. We found that the expression of CD22 and the expression of MYC, another one that we identified, are lower in cord blood 2, which actually had the lowest overall frequency at an early repopulating time. So this is a very small scale validation study, but what we think this does is present a feasible platform to potentially use omics technology to find high engrafting units. I'm not going to read through all of this because I'm already over time, but basically our work along with Dr. Kohler's work we think shows that age of the cord blood unit itself should not be an exclusionary criteria for selection, and we hope again that this transcriptomics platform might be useful to find potency markers for cord blood. I just want to mention the people who did the work and the people who got us here. All of my work begins with Hal, and I really appreciate all that he did to mentor me in the 3 years that I was with him. This work was done by myself and Scott Cooper, who's Hal's longtime lab manager. That's us last year in Miami on the beach. This was a real team effort. Our collaborators at New York Blood Center, Cleveland Cord Blood, and then at IU as well. These are all my other mentors and my funding, and I would be happy to take any questions probably after the next session because I think I went way over, so thank you.
So I thank all the presenters, and I would now like to invite for the discussion of literature and late-breaking abstracts and all the new data that is coming out, Jason.
Thanks, Dr. Parma. So I already thank the committee for this excellent opportunity to discuss some of the most recently published articles or abstracts in the field of cord blood cellular therapies. So in this talk, I'll divide it into 3 different sections based on the cellular origin of these cellular therapies, which are T-cell based, NK cell based, and MSC based. So after each section, I'll have a little bit of break so everyone can come to the microphone if they have any questions, any comments, or if they want to mention some studies I hadn't mentioned in my talk. So let's first dive into T-cell based therapies. We'll talk about our CAR T cells, Tregs, and cytotoxic T cells, CTLs. So in terms of CAR T cells, so one thing we may not be aware of is the cord blood might be an ideal source for manufacturing of allogeneic CAR T cells. So nowadays, most of the allogeneic CAR T cells in the clinical trials are used from healthy donor peripheral blood, but these cells are not HLA matched, so there is a risk of graft-versus host effects since they're does not persist very long in the human body. So usually these CAR T cells in the trials, they have to go over TCR knockouts, things like that. But cord blood actually can provide alternative to that solution because we can easily select partially HLA matched cord blood as shown here across different racial groups. So we can manufacture these allogeneic CAR T cells which can potentially avoid genome editing. So this has been an early study, which is here on the bottom, that shows these T cells from cord blood can be expanded with different sets of cytokines, and so it shows there's up to 150 folds of expansion after cytokine stimulation. So the field of cord blood CAR T cells has remained in the preclinical stage. So here I show 2 most recent published articles. On the left side is the CD19 CAR T cells in diffuse large B-cell lymphoma. So here in the bar charts, they show that after the manufacturing, most of the T cells were T-naive, which also include T central stem memory and T central memory cells, which is orange bar here. So when these DLBCL cells were added to the culture, the SUDHL4 cells, which is going to mimic the condition of our CAR T cell killing, we can see there is increased amount of these terminal differentiated effector memory cells or effector cells, but still there's a lot of component of naive cells and central memory cells. So what's important about this is that now we know the kind of the more persistent CAR T cells in human body is stem central memory and central memory. So C cells are more persistent, they are probably responsible for long-term remission in some of these patients. And on the right side is very similar to CD123 CAR T in a different disease model, BPDCN. So again, before manufacturing, most of the T cells in the cord blood are naive, whereas compared to peripheral blood, which is the blue bar here, has less naive cells. So such trend was also maintained after manufacturing, as we can see here on the right side. And again, it was in the CD4 positive T cell components, there are still significantly higher percentage of naive cells, T cells within the cord blood CAR versus peripheral blood CAR T cells. These CAR T cells, you can see there are stem central memory and central memory. Okay, so now let's talk about Treg cells. So there has been a lot of publications, both preclinical and clinical, in the field of Tregs in the past few years. So this study is Treg used in COVID-related acute respiratory distress syndrome. And it's a phase 1 multi-center double-blinded trial, and where 45 patients were randomized to 3 arms, whether a placebo or 100 million or 300 million of the Tregs. So these Tregs, they are not HLA matched, and so the patient received multiple infusions, day 0, day 3, and day 7. And these patients with COVID had pretty severe COVID. They were all intubated, and most of them were on vasopressors. The primary endpoint. It's safety and also efficacy endpoint as well, which is day 28. Survival is defined as alive, and the patient should be off ventilators. The study shows that the infusion was pretty safe. There's no infusion reactions like that. But regards the efficacy endpoint, day 28 survival was not significantly different among the three arms. So we can see here on the left side, Kaplan-Meier curves of overall survival. There is a trend of improved survival in the 100 million group, but it was not statistically significant. So this next study, it studied the use of Treg cells in lung inflammation, kind of laid the standard why Tregs might be helpful in patients with lung injury, such as COVID-related ARDS. So in this mouse model, with SLE human cells to induce lung injury, and the cord blood cells was infused multiple times. And when the researchers look at the Treg cells within the lung tissues, you can see there is increased amount of Tregs in the lung. Here showing the blue bar is the left lower chart. And there is decrease of CD8 positive cells, which is the inflammatory cells that are responsible for lung injury. So again, very similarly on the right side, IHC graph also shows there is decreased CD8 expression T cells within the lung tissue. So in addition to that, Treg cells has also been studied in kind of other conditions such as bone marrow failure syndrome. So in this study, it was published 2 years ago. It's abstract with a recent update on this, where 9 patients, they were had treatment refractory primary bone marrow failure syndrome, such as primary myelofibrosis, PMF, aplastic anemia, AA, or myelodysplastic syndrome, AA, MDS. So they received, this is at least 3 out of 6 HLA matched Tregs, and they only received single infusion. So in the swimmer plot, we can see at 12 months follow-up, majority of patients had some improvement of their symptoms. And you can see here with the kind of the blood bag sign, which shows there is a decreased burden of transfusion, and there is this malady sign, which shows there is decreased symptom burden for MPN. And this study published this year looked at the combination infusion of Tregs with CAR T cells. So the goal of this study is to see if the Tregs can have any effect on the CAR T cells. So on the left side, the graph shows an experiment in a mouse, rat mouse tumor model, where the mouse was given as a CAR T cells or CAR T cells in combination with cord blood cells, which is the purple line. So we can see here there is no significant difference regarding the tumor burden when the Tregs were added to the CAR T cells or not, which means the cord blood Treg cells does not interfere with CAR T cell tumor clearance. So on the right side, they also look at the serum level of different inflammatory cytokines, such as interferon gamma, IL-1 alpha. Again, so in the group with co-administration of CAR T and Tregs, which is the purple bar, it has decreased expression of these inflammatory markers compared to CAR T alone, which is the teal bar. So what this means is the co-administration of CAR T with Tregs does not affect its efficacy, but maybe it can decrease inflammatory markers, which can be associated with side effects such as CRS or ICANS in CAR T cells. So Tregs can also be used in other non-malignant conditions, other inflammatory conditions such as SLE. In this paper published last year, it's a mouse model of SLE lupus, where they received multiple infusions of Tregs, and what they found is there's a decreased amount of CD8 positive cells, both in the peripheral blood and spleen, we show here on the left lower graph. And also these mice, they have improvement of their skin symptoms. They're shown here on the right side. This is another trial of Treg, which is clinical trial, which was presented as oral abstract in the past, ICT 2023, where as researchers look at the Treg cells in patients with ALS. So it includes 6 patients with ALS. They received multiple infusions, which the schedule here is shown here below, where they received first weekly infusion for 4 doses, and followed by consolidation of monthly infusion for 6 months. And they have response of stable, so they can go on to this maintenance phase. So altogether, there are 6 patients. At each infusion is about 100 million cells. And these Treg cells were not HLA matched. So what they found is there's no infusion reaction or any grade 3 or 4 severe adverse effects. And also there's no HLA antibody developed in this population. But in terms of preliminary efficacy outcomes, as I shown here, in the middle graph, there is a decrease of plasma neurofilament, which is a marker of disease activity in ALS. And on the right side, the curves showed their clinical performance, which is determined by this ALS FRS-R score. So you can see here before the infusion, which is part of the curve on the left side, there is a steady decline of their physical condition performance in these patients with ALS, where after post-treatment, we can see there is stabilization of the curve, which means that symptoms also stabilized after infusion of these Tregs. So basically, this study shows that the Tregs is safe in patients with ALS and associated with stabilization of symptoms after infusion. For the last part of T-cell therapy, it's targeted T-cell CTLs. So we all know that the T-cells in the cord blood is mostly naive and like antigen-naive cells. But actually, we can still isolate, expand antigen-specific CTLs from the cord blood, but less so compared to the peripheral blood. So we can see here on the upper graph where the researchers try to isolate, expand MART1 reactive CD8 cells. So MART1 is an antigen on melanoma cells. So these CD8 positive T cells are supposed to have activity against melanomas. So we can see here with stimulation of IL-7 and IL-15, there is not a significant expansion of the cord blast, which you can see is a much larger expansion in the peripheral blood, which is on the right side. And also, it's not only these cells, they cannot expand very well. They expand the CTLs, they don't have a strong cytolytic activity, which is determined by the granzyme B. So you can see here on the left side, cord blood, there is not much secretion of granzyme B compared to these CTLs isolated from the peripheral blood. However, there's another component of T cells in the blood is the gamma delta T cells. So, most of T cells in the human, like in the peripheral blood, is alpha beta, traditional alpha beta T cells. The gamma delta T cells persist in very small amount in both cord blood and peripheral blood. But the authors here showed that the cord blood gamma delta T cells actually has a stronger expansion capacity when compared to peripheral blood gamma delta T cells, as I shown here on the left upper curve. And the other things they find is these gamma delta T cells is of different phenotype. So the majority of the cord blood gamma delta T cells were delta 1+ cells, and whereas in the peripheral blood is delta 2+ cells. So there isn't much study on the delta 1+ cells, but generally speaking, it's believed to be more kind of long persistent kind of type of gamma delta T cells in human body. And then on the left lower graph, they studied in vitro activity of these isolated gamma delta T cells from the cord blood using different AML cell lines. So it showed it has in vitro activities, but it does not have cytolytic activity against CD34 plus cells, which is a healthy tissue. So this means these gamma delta T cells are selective against tumor cells, but has less cytotoxicity against normal tissue. So finally, the lower middle graph shows that in a mouse PDX model, where the gamma T cells was also effective at eradicating the AML cells in the model. Okay, so with that, I reviewed some recent publications in terms of T-cell-based therapies. And if audience have any questions, they can come to the microphone, any comments, and me and Dr. Parma will have you answer them.
We decided to break our presentation because there is so much data. So like Jason said, he just presented the T-cell based therapies, and if there are any questions regarding that, please ask those now. But until then, I have a question for you, Jason. I think the source of cord blood for generating CAR T cells seems very exciting.
Yeah.
So in the data review, did you see any comment about the HLA matching? Because right now, the allogeneic peripheral blood-derived CAR T cells are going through lots of machinations in terms of whether they are deleting the HLA marker or giving CAM-path before infusion. So in your review, where did you see the role of cord blood as a source for CAR T fitting in?
Yeah, so there isn't any clinical trial going on regarding human with cord blood-derived CAR T cells, but it's definitely very kind of a good idea because cord blood can select partially HLA matched T cells to manufacture CAR T cells, and hopefully these CAR T cells will have less graft host effects, and they can persist longer in the human body. Whereas, as you mentioned, the CAR T cells from the peripheral blood from healthy donors, there's a big problem for HLA mismatch in these cells. They don't persist very long.
Do you think there would be any hesitation looking at the CTL data to think that CAR T cells derived from cord blood may be less cytotoxic, or they may be less effective compared to peripheral blood?
Yeah, so most of the T cells in the cord blood, they're kind of naive type or central memory type. So if borrow data from the peripheral blood, these kind of subtype of T cells they have more cytotoxicity and they persist longer. So I would be surprised if these cord blood-derived CAR T cells were less effective than peripheral blood-derived CAR T cells.
My last question would be that when you presented the CTL data, did you see any viral CTLs from cord blood?
Yeah. So there are a couple publications on viral CTLs as well. But as I mentioned, the cord blood T cells, they are mostly naive. They haven't experienced these virus antigen before, so there has not been as good results as peripheral blood-derived viral CTLs.
But what about priming? I know that there were a couple of strategies in which they are priming the cord blood T cell, especially the viral CTLs.
Yeah, I think there was a couple of papers that show you can actually still kind of expand and prime these virus-specific CTLs. Yeah.
Okay, thank you. Let's proceed to the next part.
All right, so next part we talk about NK cells. Some of the topic we mentioned briefly yesterday was Dr. Pauline's talk. So basically NK cells, the first is kind of unmodified NK cell infusion. So it has been a lot of studies in the past, but most of these NK cells are derived from kind of healthy donor bone marrow NK cells. There hasn't been much study about cord blood-derived NK cell and modified infusion. So on the left side, there's this study, earlier study where NK cells combined with autologous stem cell transplantation, where 12 patients with multiple myeloma, so they underwent NK cell infusion, which is at least 4 out of 6 HLA matched. So these NK cells, they were infused between the melphalan conditioning and the stem cell infusion. So the melphalan here acts both as kind of conditioning regimen and also lymphodepletion to ensure successful NK cell expansion. So in this trial, they did not notice any GVHD in 11 of 12 patients engrafted. But one important observation they find is that these donor-derived NK cells, also they are HLA matched, the persistence was not very long, so only on the day 28, there's no detectable donor-derived cord blood NK cells. So on the right side, it represents the more kind of popular ways of using NK cell infusion nowadays is to differentiate CD34 positive hematopoietic stem cells, HSCs, using a serial cytokines to kind of differentiate these stem cells into NK cells. So this is a phase 1 clinical study, also published a couple of years ago, where it's 10 patients with AML in complete remission, but they are ineligible for transplant. So these patients, they received partially HLA matched NK cells, which were differentiated from the stem cells. So this patient received 3 dose levels. They received after lymphodepletion treatment. And again, it's very safe. There's no GVHD. But again, what they notice is very limited persistence. As I shown here on the lower graph, we're using a chimerism surrogate for persistence. They find that all these cells were gone by day 14. So the next strategies that have attracted much attention last year is with NK cells in combination with NK cell engagers, NKCs. This is what Dr. Pauline talked about yesterday. It's AFM13, which is a bispecific antibody with CD30, which can bind to the tumor cells, and CD16, which can complex with NK cells. So they infuse it is pre-stimulated and pre-complex manner, just because these NK cells, they were stimulated with cytokines, and then AFM13 was added to the cord blood NK cells to pre-complex. And this complex NK cell with AFM13 was then infused to patients after a lymphodepletion treatment, and then followed by 3 weekly infusion of AFM13 only. So the trials, they did this up to 4 cycles, so every month, every 28 days, these patients, they come back, they receive lymphodepletion treatment, and they receive the infusion of this cord blood-derived NK cells plus NK cell engagers. So in this study of 41 patients, again, most of them has received CD30-directed treatment before. The treatment was pretty safe. There's no CRS, ICANS, or GVHD, but it showed very early good efficacy, as in 35 patients on those 3 groups, there was 94% of overall response rate. But I'll draw attention to the swimmer plot on the left lower side, where the red dot I highlight here represent a relapse or a disease progression. And we can see with this very limited follow-up, we start to see some relapse of this disease progression in this patient. So we're still waiting to see in the long term whether this treatment is going to result in long-term remission, or this patient will have short relapse. Another treatment that has been attracted great attention in recent years is the CAR-NK cells. This study is mentioned multiple times. So I'm just going to go over it briefly. It's the NK cell, CAR-NK cell with a design shown on the right upper side. So we know this CAR-NK cell is pretty safe. There's no CRS or GVHD, and the response rate, the initial response rate is pretty high, 73%. Also, the CAR copy can also be detected in the peripheral blood up to 1 year, as shown here in the left lower graph, which is the number of CAR copies. However, when the researchers use flow cytometry to look at these T cells, CAR NK cells, what they find actually is these CAR NK cells, they kind of have a steep drop in the peripheral blood from day +8 compares to day 21, as I show here in the gating, where they use this donor HLA-3 is a marker for the CAR NK cells. You can see it was 60% at day 8 and went down to 0.009% at day 21. So from other trials, not cord blood-derived CAR NK, but from other like bone marrow-derived CAR NK cells, we know a big problem for CAR NK cells is their short duration of response. And from the same group of MD Andersons, they had a recent published article studies the mechanism why these CAR NK cells might be of short persistence. And they found this mechanism called trogocytosis is responsible for the process. So basically on the left upper side, the graph, they use CD56, which is a whitish dye to show the CAR NK cells, and CD19, which is antigen, show here on the surface of Reggie cells. So when CAR NK cells and Reggie cells were co-cultured together, you can see here again the CD19, which is here on yellow, can also be seen on part of the CAR NK cells. What it means is that these CAR NK cells, when they get in contact with tumor cells, they can actually eat up part of the membrane and take that up as self-membrane. And this process is called trogocytosis. And the result of this is that these CAR NK cells, they start to express CD19 as well. And because of that, they have the anti-CD19 CAR on the cell surface, and so they also express CD19, so they start to kill each other, it's called a fratricide. And from the data from the last trial, they divided these patients into two groups, trogocytosis high group versus trogocytosis low group, based on the CD19 expression on the CAR NK cells. Also, you find that for the trogocytosis low group, and there is a persistence of B-cell aplasia, which is a marker of effective CAR NK cells. Whereas on the right side, for the trogocytosis high group, which means these cells that take up a lot of the membrane component from the tumor cells, as they have early loss of B-cell aplasia. We can see it's early as day 7, these B-cells start to kind of recovery, which means these CAR NK cells, they were not really affected anymore after day 7. So there has been a couple of CAR NK cells right now going on, most of them in China, United States, and MD Anderson. So these are all cord blood-derived CAR NK cells. We can see there is a broad spectrum of targets that use not only CD19, but other targets, CD5, CD70, or BCMA. But only one trial has some results, which is a trial published in New England Journal of Medicine, but other trials we're still waiting for the results readout. Okay, with that, I'd like to pause and ask the audience if any comments, questions regarding NK cell treatment.
Okay, while we are waiting, I will ask you a question. What about the comparison of peripheral blood versus cord blood CAR NK? Because, just for the same tone, when we looked at the T cells, is there any comparison data or there is some input?
Yes, there's comparison data. So in terms of amount, so cord blood, they have more percentage of NK cells, whereas in the peripheral blood, it's less percentage of NK cells. That's the difference of the amount. In terms of the function of NK cells, so the NK cells in the cord blood, they're actually less, they're more naive, less mature. So there has been some studies that these NK cells are usually like CD56 stem cells, so not as kind of effective as NK cells from the peripheral blood because they're more naive. But actually, the other studies show that when you use some cytokine stimulation, you can still bring the cytotoxicity of these cord blood NK cells to the same level as peripheral blood NK cells.
If I can figure out how to make the mic work. Sorry if this is a really naive question. I deal with cells much higher on the hematopoietic hierarchy. But NK cells are not super long-lived cells, right? So, I mean, you kept mentioning that the persistence wasn't long, but do we really expect the cells to stick around once they're in the bloodstream? I mean, without, I guess the question I have is anybody looking into ways to put in more primitive cells that could, continuously replenish the NK cells? I guess it's not terribly surprising to me that a fully mature immune cell is being cleared relatively quickly.
Yeah, that's a good question. Actually, there's a subtype of T cells, NK cells, like NK memory cells, which can be produced by a couple labs with a stimulation of certain cytokines. So these NK cells, they have been shown to can persist in the body for a couple months. But in the clinical studies, still, with the cytokine stimulation, the persistence is still not very good. So it's still unsolved question regarding the persistence of NK cells.
So, the data that you presented for Hodgkin lymphoma looks very good. My question is, that data is CAR-NK in combination with the bispecific. So, is there any thought process of what is attributable to bispecific versus NK and the synergy? How much can you speak to that?
Yeah, I think the combination of NK cells with NK cell engagers, it's more like CAR-NK cells. So it's more specific against antigens. So when compared to CAR-NKs versus NK plus NK cell engagers, so I think the benefit is that with the same platform, NK cell engager, which is non-sterile product, plus a cord-derived NK cells, it's probably just a platform can be extended to other treatment, other conditions pretty easily. Just swap out the engager and use to treat other conditions. Yeah.
Okay, thank you.
Okay. All right. So for the last part, we're gonna talk about MSCs. So MSCs has been a lot of study in regenerative medicine for many years. And on the left side is meta-analysis that look at different studies of MSC in neurologic disorders, which could include traumatic spinal injury, multiple sclerosis, ischemia, stroke. And the author concluded that there is no clinical benefit in these early phase trials, which show here in the forest plot, which is MSCs in patients with traumatic spinal injury, and they look at improvement of their symptom score is SIA score, and there's no significant improvement before and after treatment. On the right side is another very common use of MSC is in regenerative joint diseases such as knee osteoarthritis. And most of these studies come from Korea, and there is very big control trial, randomized control trial. This is where 114 patients were with knee cartilage damage were randomized to receive cord blood MSC or microfracture, which is a technique we don't use very often here in the United States. Basically, what they do is they use a needle to damage your knee, and in that way, the knee can kind of recover itself and can alleviate some of the symptoms of osteoarthritis. So when compared to this technique, the cord blood MSC was able to achieve a great improvement in the cartilage grade when they have the second look arthroscopy, and the patient has improved pain control as well, which is shown here on the lower side of on the table. Another very common use of MSC is in inflammatory diseases such as COVID-19. So since advent of COVID-19, there has been a lot of trials of MSC in COVID-19. So this is, again, a meta-analysis that look at the MSC used in COVID-19. And what they find is there is the forest partial, there is a significantly reduced mortality. They summarize all the trials here with RAS ratio of 0.63. But the authors still mentioned that you have to be cautious because there is a great heterogeneity in this population and there's difference in terms of MSC manufacturing, the doses of MSC, and the time of delivery of these cells. And this is another more recently published article from UK, which is a phase 2 realist COVID trial. It's a multi-center randomized placebo-controlled trial in UK, where the researchers used the MSCs or cord-derived CD362 enriched MSCs, which CD362 enriched MSCs is supposed to be more kind of immunosuppressive and more effective in this setting. So in this trial, there are 59 patients. They were randomized to receive either placebo or the cord blood MSCs. And the primary efficacy outcome was day 7 oxygen index, which is defined as airway pressure times FiO2, which is a physiological measurement of the severity of ARDS. So we can see there's no significant difference regarding the oxygen index through the treatment course. So this was an active trial. And another use of MSC has been draw a lot of attention in recent years is MSC-derived exosomes. So the thinking behind this is that MSC has more kind of immunotolerance, so these exosomes has kind of more low immunogenicity, and they also have kind of tumor tropism of these MSCs to the tumor site. So in this preclinical study of cord-derived MSC in a mice model with salpingitis, which is inflammation of the fallopian tube of the uterus. And so you can see there is decreased inflammation here on the left lower graph. And the mechanism behind this was they found is there is a transformation from macrophage 1 to macrophage 2. So macrophage 2 is this component that it's less kind of inflammatory, but more kind of protective effect of macrophages. But that's just tip of iceberg regarding the publication MSCs, because you can see here a simple search in PubMed, you can see there is a steady increase in the publication of MSCs over the years. So I just mentioned a couple of the publications that interest me, but a lot of other publications I wasn't able to include in this presentation. All right, so with that, I do have any questions regarding MSC-based treatment.
Okay, it's me again. So one of the items, Jason, that really plagues this field is, especially with MSC's quantification and also potency assays, is there any movement that you have seen in the literature on that aspect? Because, not cord blood derived, but, Mesoblast did a great achievement in terms of applying MSCs for GVH, but were not able to successfully productize it. Mm-hmm. And one of the biggest pushback was potency assays, predictive analytics. So have you seen anything that caught your eye during literature search, which was not presented?
Yeah, I don't have a lot of knowledge on that.
Yeah. So I think one of the biggest things, at least very impressive here, is that so many clinical trials are happening with umbilical cord blood derived cell therapy products, whether it is MSCs, whether it is Treg cells, whether it is CAR-NK. I think CTLs are a little bit lagging behind because the field is so advanced. But one unifying message, at least that comes out, is that there is no major side effects. And I think that is really what can propel this industry forward, especially with the umbilical cord blood as a source for cellular therapies. So, I think I'll switch it back to you so you can give the home message.
Yeah, just have some kind of high-level take-home message from this presentation. I just want, hopefully with this presentation, I can convince you cord blood is an excellent source for cellular therapy because of the low immunogenicity, and we can produce kind of allogeneic infusion, which does not have gravis host effects and can persist long in human body, and there's a naive phenotype which can hopefully have higher expansion potential, and they are easily available from the cord bank. And the various components of cord blood shown here, T cells, NK cells, MSCs, can all be utilized in cell therapies in various indications, not only in heme malignancies or stem cell transplant, but also in other benign conditions, inflammatory diseases, rheumatologic diseases, COVID-19, other different malignant diseases such as solid tumors and other hematologic malignancies. Yeah, with that, I thank for your attention. I'll give it back to Dr. Palmer.
Thank you, Jason. That was really amazing, and thank you for doing such a comprehensive view. So unless there are more questions for our abstract presenters or for Jason, I would like to close the session. I thank the speakers and the audience. Please note that the Meet the Author poster session and reception is open. It's located in Americana 1 and 2. We have saved some time, but I think that overall it's just so impressive that cord blood as a source can have so many implications. And I think Jason's slide had very nicely presented. I remember one of the figures he has is that it's almost like you can fragment the cord blood into different compartments, and each compartment has utilization in different areas. So I think I agree with Jason, we are just scratching the surface, and future is ahead of us. So thank you, everyone.